Dear colleagues, ladies and gentlemen, it's an honor to welcome you to the second World Sepsis Congress satellite session that the Global Sepsis Alliance is convening on the margins of the World AMR Awareness Week. And the current session is brought with the support of Menarine Group, our partner organization. And as you know, the satellite session is part of the 3 series of webinars dedicated to the World Antimicrobial Awareness Week with the support of Menarine, Biotest, and bioMérieux. We are thrilled to have more than 600 registrations for the current seminar, and we hope that you will find the theme of the session, AMR and Sepsis in Cancer Patients, both interesting, appealing, and addressing the interconnected global health threats facing our communities and health care settings. Without much ado, I would wish to set the stage on sharing some of the latest estimates on sepsis, AMR, and the both clinical epidemiological and clinical outcome data for cancer patients. I'm delighted to be presenting to you the excellent panel of speakers whom we will be introducing during their presentations. As mentioned, we'll be exploring the interconnection between sepsis and AMR and their relevance to the incidence and clinical outcomes of patients affected by oncology. Based on latest estimates that are recognized by the World Health Organization and stemming from the landmark Lancet publication, every year sepsis affects nearly 15 million children and women globally, and causes at least 11 million deaths, including 1 in every 5 deaths. Globally, up to 20% of global mortality is related to sepsis. 55% of the global sepsis burden affecting low resources, and 40% of the sepsis cases recorded in underfed populations. This is the data that is initially recognized by WHO. But in October, the same sepsis collaborative group from Washington University, the Institute of Health Metrics and Evaluation team, and their collaborating partners published another groundbreaking study on global health, documenting that based on the modeling of the sepsis data, only in 2021, and this is the year we have to remember, sepsis has affected 166 million people, and estimated 21 million deaths were directly associated or the intermediate cause of death. All cause sepsis-related deaths were estimated at 31.5% of total global deaths. And we very much encourage you to look up for the publication and see the latest estimates. As for the global burden on AMR, the antimicrobial resistance collaborators also published the study outcomes in 2020. And the current estimates are also the officially known and widely circulated numbers about the antimicrobial resistance, estimated 1.27 million deaths in 2019 were directly associated or attributable to antimicrobial resistance, and overall AMR has contributed to 4.95 million deaths. And I think it's very important to document that the study from Rood and colleagues from the global burden of sepsis has substantially contributed to the modeling of the current AMR estimates. The source of data on antimicrobial resistance globally stems from the same group of collaborators and from the same modeling exercise. And the current estimates on AMR are also officially recognized and published data from WHO. And we are moving to the most important slide as an introduction to our current theme on AMR and sepsis. The Institute of Health Metrics and Evaluation and the Oxford University have launched a special database, the WISHub, that demonstrates the interrelation between AMR and sepsis. The 4.71 million antimicrobial resistance associated or attributable deaths are part of the 21 million estimated sepsis deaths documented in 2021. So when we speak about antimicrobial resistance, we definitely have to be speaking and aligning our policies and programs with sepsis, because sepsis is the human face of antimicrobial resistance. In relation to the current new data set, we very much encourage our colleagues globally to visit the following website of the microbe WISHub, hosted by Institute of Health Metrics and Evaluation and University of Oxford. And on the current database, you will be able to see both global, regional, and country estimates on sepsis, bacterial infection, as well as antimicrobial resistance. For example, based on the example of my country, Georgia, in 2021, 19,663 sepsis-related deaths were estimated. That included 2.7 thousand AMR-associated deaths. You will be really astonished by the depth of data and comparability possibilities and interactive map that the current site provides. Finally, when we speak about the epidemiology of sepsis and antimicrobial resistance in oncology, one of the latest study from Tura and colleagues documented that 9.1% of cancer patients, 1 in 11 cancer patients, developed sepsis. Cancer patients have almost 10 times higher risk of sepsis and up to 3-fold higher risk of drug resistance compared to non-cancer patients. And risk factors for AMR and sepsis in cancer include previous antibiotic exposure, invasive procedures such as catheters or mechanical ventilation, GVHD, stem cell transplant, and ICU hospitalization. And when we speak about the clinical outcomes from sepsis and AMR in cancer patients, sepsis is a major mortality driver in oncology, increasing 90-day mortality by more than 13-fold in hospitalized cancer patients. And carbapenem-resistant and multi-drug-resistant organisms increase mortality by 10 to 15-fold compared to susceptible infections. And despite improvements in survival, mortality remains higher in hematologic malignancies versus non-cancer sepsis, based on the binational study conducted in Australia and New Zealand ICU cohorts. In terms of way forward, what we need, first of all, we still don't know enough when we speak about sepsis and AMR in cancer patients. We need more clinical epidemiological data to track sepsis and AMR in cancer patients. We need higher quality evidence on bidirectional relationships to inform guidelines and therapeutic decision-making, targeted research in risk stratification, diagnostics, and treatment, innovations in antimicrobials, rapid diagnostics, infection prevention measures, and immunity supporting therapies. Finally, until I hand over to our brilliant speakers, I would like to inform our audience that from today, you can not only join the Global Sepsis Alliance as institutional members and join our fight against sepsis, AMR, and especially this medical emergency in immunocompromised individuals, but you can also join us as individual member of the GSA. And every individual member, depending on the choice of the associate, full, or honorary membership, will be receiving this certificate of membership. And we are grateful for hundreds of members who have already joined us over the last week. And we hope that this membership platform will attract even more supporters and colleagues to reinvigorate our fight against sepsis for saving lives. Thank you very much for your attention. And now I have the honor to hand over for the first presentation to Professor Djillali Annane. We have a pre-recorded presentation from Professor Annane, who is the honorary dean of the medical school in Simone Weil and the steering committee member of the European Sepsis Alliance, one of the distinguished experts in sepsis research and clinical practice from France, and we will hear from his outstanding experience from the French research and the practice.
Good afternoon, everyone. So in 10 minutes or so, I will share with you some ideas about common things between sepsis and cancer. So here are my disclosures. Yeah, I think really that cancer and sepsis are the two sides of the same coin, that inflammation is is a problem of both disease, cancer and sepsis. And indeed, we have figured out for at least 1 or 2 decades now that basically the immune system is failing in case of cancer cells for cancer or in case of pathogen invading a body. And very importantly, there have been a number of targets, both at the cell levels or tissue levels, both for cancer and sepsis, that have provided important information to introduce immune therapies in cancer, very successful for now in cancer, and very likely to be successful in the future for sepsis. So, and indeed, as shown on this cartoon, one can see that the immunity cycle for cancer and pathogens are very similar. One can see here, step one is the release of the cancer cell antigens or the release of pathogen antigens, and then the same pathway. The next step is antigen presentation, whether from cancer cell or from a pathogen, and is priming and activation of the immune system. And then the activated immune cells will traffic to the tumors or will traffic to infection site, and then infiltrating the tumors or infiltrating the infection site. And at this level, the T cells will recognize either the cancer cells or the pathogens. And following the recognition, activated T cells are able to kill the cancer cell or the pathogens. So really, there are tight connection in between the mechanism of cancer and the mechanism of sepsis following pathogen infections. Main aspects of molecular basis for cancer as for sepsis is the mechanism of cell death. And we have learned a lot the past 50 years about how cell dies. And we know that there are many pathways to death for cells. And one of the most recent discovered pathway is the one involving copper. And this appeared to be very important in the field of cancer, biology, and treatment, as shown in this cartoon again. Copper is first reduced through reductase into copper positive anion, cation 3, then is transported across cell membrane. And there are mechanisms in the cytosol involving ATP pumping to avoid accumulation of too much copper in the cytosol. And then copper bind to chaperone proteins like COX-17 will enter the mitochondria and interfere with electron transfer chains within the mitochondria, impacting on the mitochondrial genetics and consequently impacting the function of organelles. In the past 5 years, we have been at the Sepsis Comprehensive Centers in Paris collaborating with the Cancer Comprehensive Center Curie Institute. And that collaboration resulted in the discovery of a common pathway between metastatic cancer and sepsis that relates to copper signaling in the mitochondria as a main driver of inflammation. So we did a number of experiments using activated macrophages, showing that they express CD44 and that they accumulate in the cells copper. And we demonstrated panel D and E that accumulation of copper by the activated macrophages is related to CD44 expression. Also, it needs hyaluronic acid, as shown here, which increases the uptake of copper. And here one can see the accumulation in the merge picture, co-localization of hyaluronic acid and copper. And further demonstrated in these two additional analyses. Then we know that metformin can actually catalyze copper, but we tested metformin that has a marginal effect on activated macrophages. Therefore, we developed a new molecule, initially called LCC12. Now we are calling it subformin, and we have demonstrated that this subformin is able to downregulate the activation of a macrophage, as shown on panel C, and here showing how LCC12 or subformin bind to copper and sequestrated copper, preventing the copper activation of inflammation. Furthermore, we demonstrated here that LCC12 accumulates in the mitochondria as marked by cytochrome C. We further demonstrate that the LCC12 binds to copper, accumulates in the mitochondria, highlighting the presence of a druggable mitochondrial copper pool. And we figure out that mitochondrial copper increases during macrophage activation, and the copper is transforming NDH into NAD+, and this is fully blocked by LCC12, as shown in panel D there. This resulted in modification in the function of the activated macrophages. So after LCC12 treatment, there are different types of macrophages, different from the non-activated and different from the activated. And that difference mainly stands in the upregulation of inflammatory genes, as shown here in panel B. And when treatment with LCC12 is completely downregulating these set of genes. And when we run the gene ontology analysis, we were able to figure out what are the genes that are downregulated upon treatment with subformin. And then we move to in vivo analysis to demonstrate that subformin was able to protect from the mice from LPS-related deaths or CLP-related deaths or SARS-CoV-2 or influenza-related deaths. And that was mediated by the decrease of copper uptake. And in additional analysis, we found again in a cancer model in mice that LCC12 was able to prevent metastasis from tumors in the animals. So basically, it is obvious that the future needs that cancer specialists and sepsis specialists talk to each other to improve outcome from cancer and from sepsis. And one can recognize here Marie Curie from Paris, and William Osler. And again, these are two examples of fantastic scientists in their field. And now we need to have all people working in the field of sepsis, collaborating with people in the field of cancer, breaking the walls in between the different these two domains. Thank you very much for attention.
We're grateful to Professor Annane. Unfortunately, he cannot be in live with us, but any questions related to this truly insightful presentation, please share with the Global Sepsis Alliance, the organizers of the webinars, and we'll make sure that your questions reach Professor Djillali. I think that the concluding statement that we have to speak is definitely that we are hoping to start with our first seminar on sepsis AMR and interaction with oncology. Multidisciplinary approach within oncology is already important, and now we're speaking of exploring further interactions between these two important and extremely complex issues. It's my honor to give the floor to the board of the Global Sepsis Alliance, Professor Naoyuki Matsuda from Naoyuki University, and the leader of the Japan Sepsis Alliance, one of the extremely valuable member of the Global Sepsis Alliance, who have been leading both the national and transnational campaigns and capacity building initiatives. Professor, over to you.
Thank you very much. Share slides. Sorry.
No problem.
No problem, sorry.
We have a slight technical issue here, however, until Professor Matsuda shares his slides, I would like to welcome more than 120 participants who are currently watching the session. I welcome colleagues from Ivory Coast, Italy, Mongolia, Poland, Georgia, and very much encourage each of you to send your questions by the chat. I think we're ready, Professor Matsuda, please.
Yeah, thank you very much. I will share a perspective on sepsis in the content of cancer care. It is great pleasure to be here with all of you today. Thank you very much. As a third presenter, the key message I'd like to emphasize is sepsis in cancer patient is often detected late unless clinician remains vigilant. During cancer therapy, especially chemotherapy, leukopenia and lymphopenia are common since white blood cells are critical for host defense. Their reduction makes clinical evaluation more difficult. Fever may rise, yet inflammatory markers and immune response may not follow typical patterns. These challenges are due not only to the underlying cancer biology, but also to the effect of anti-cancer therapy treatment. Today, I will share with you these important considerations. This figure is an adaptation based on the first original sepsis 1 systemic inflammatory response models, which I modified to illustrate a second hit concept in several types of sepsis. Background conditions such as cancer, stroke, heart failure, renal failure, diabetes, trauma patient, and now a newborn elderly person. In these conditions, particularly in Japan, aging-related chronic diseases such as hypertension and diabetes create vulnerability in patients, as well as in Japan, in the world. Social and environmental stresses such as trauma, disasters, conflict, or major accident, of course, earthquake, represent at the first attack for us like cancer, when infection develops in this compromised condition, it acts as a second hit, leading to uncontrolled inflammation and cell death, ultimately resulting in sepsis. This slide shows Japanese Japanese Sepsis Alliance data. Sepsis in cancer patient should be prevented whenever possible. Fundamental infection control measures such as contact precaution and the WHO's 5 moments for hand hygiene remained crucial and important. In the world, including Japan, sepsis has gradually become integrated into national health policy within the 5 major diseases, including cancer. However, when infection occurs in a cancer patient, this is often attributed solely to cancer, even when sepsis is a true death cause. For many years, even specialists in oncology and neurology in Japan were unfamiliar with the term sepsis until around 2015 or 2020. This misunderstanding motivated experts from the Global Sepsis Alliance and critical care communities, including us, to avoid that. These patients not simply dying from cancer, they are dying from undiagnosed sepsis. According to the Japanese National Sepsis data published in Critical Care, as the most common underlying condition among sepsis patients, approximately 35%, this data shows, is cancer. This demonstrates the cancer not only compromises general health, but also increases vulnerability to infection-related organ failure, worsening prognosis. Numerous analyses now confirm that sepsis play a significant role in mortality among cancer patients. These two US datasets demonstrate the same trend. Incidence of sepsis is rising because of detecting sepsis. We can detect sepsis as the diagnosis of sepsis in cancer patients is becoming more accurate and more frequent. Global recognition improves sepsis recognition. We now understand that sepsis is deeply linked to cancer outcome worldwide, not only in Japan, all over in the world. Only the greatest diagnostic challenge is that cancer can biologically mimic sepsis. And this slide shows the mimics and same pathway between cancer patient and septic patient. Cancer generates inflammatory signals during damage-associated molecular patterns, DAMPs patterns, triggered by tumor progression, cell death, and abnormal glycation, hyperglycation. Sepsis in contrast is driven by pathogen-associated inflammation, pumps pattern through pumps. Yet both pathways activate similar receptor during toll-like receptors, TLR, and RAGE, receptor of advanced glycation end product. And both affect mitochondrial integrity and cell death pathway. Therefore, the biological response to cancer and sepsis is not separate. It's overlap and often is very, very difficult to distinct. This figure is from a review I published more than 10 years ago. Since then, intracellular signaling pathways have become increasingly well understood. These mechanisms occur not only in immune cells, but also in endothelial cells and organ-specific tissue cells, leading to amplification of inflammation, acceleration of cell death, fibrosis, loss of functional capacity. This explains why organ becomes increasingly fragile during systemic inflammation and cell death. Because cancer already disrupt immunity through damages to molecular pattern pathway and anti-cancer therapy, a patient may appear similar to sepsis even before infection occurs. Therefore, distinguishing infection-induced sepsis from cancer-related inflammation can be extremely difficult based solely on clinical signs. For this reason, it's essential that both healthcare professionals and those involved in cancer care understood sepsis clearly and proactively. Today, we use this quick SOFA score to support early recognition of sepsis. If two or more of the three components present in the suspected infection, altered mental status, altered consciousness, respiratory rate over 22 per minute, systolic blood pressure below 100 to mercury millimeter Hg, then this is a high risk that organ dysfunction will develop within a day, days. Cancer patients are not an exception. Perhaps they should be considered even high risk. Now, as we recognize that cancer patients are prone to systemic inflammation and organ dysfunction similar to sepsis, it becomes essential that we avoid using antimicrobial agent indiscriminately. Accurate assessment of whether an infection is truly present must guide our decision making. The theme today's session is AMR. In this content, cancer patient present and unique challenge precisely because they have cancer. The diagnosis of sepsis can easily be delayed. Therefore, it is crucial that clinical correctly understanding the term of sepsis, the definition of sepsis, very important for us understand over only through vigilance and timely recognition can we prevent delayed diagnosis and improve outcome for cancer patients who may develop sepsis. And this is my summary. Thank you very much for your attention. Thank you. Thank you very much.
Mariam, you're on mute.
Professor Matsuda, thank you so much for sharing the impressive results from more than 2 million septic patient cohort from Japan. And it's striking how we see the similarities of challenges in dealing with sepsis and AMR in cancer patients, both in France and Japan, and the common recommendations that come not only from the clinical management perspective, but for the need for increasing awareness and capacities of oncologists and emergency ICU or any other healthcare providers dealing with the conditions. Thank you very much.
Thank you very much.
I use the opportunity also to welcome colleagues from Tanzania, Uzbekistan, Greece, Peru, and Nigeria who have joined our chat of the session, and we look forward to your questions and feedback to the session. The next presenter is our dear Professor Evangelos Giamarellos-Bourboulis. I believe that he doesn't need too much introduction, as his name is among the most widely published researchers and authors. Professor Evangelos is the chair of the European Sepsis Alliance and the board member of the Global Sepsis Alliance, and he is currently representing the Kapodistrian University of Athens. Evangelos, over to you.
Thank you very much for the nice introduction, and thank you for giving me the opportunity to speak today for a challenging topic, which is sepsis in immunocompromised patients. And actually, when it comes to immunocompromised patients, all of us, what we have in mind is a patient probably with cancer, probably a patient with neutropenia, probably a patient with a hematologic malignancy. But I would like at the beginning of my talk to challenge you and tell you that probably this is not the case. This is my conflict of interest disclosure for this presentation, and allow me to walk you to what is nowadays the most common disorder. The most common disorder and comorbidity, because being at an immunocompromised state means that you have a fundamental comorbidity. So the most common comorbidity nowadays is diabetes mellitus. And it is the modern, let's say, pandemic. And what you have here is nothing more than a survey of 55 non-infected, healthy individuals. 20 of them, they do not suffer from type 2 diabetes mellitus. 35, they do suffer. Those who suffer are in blue. Those who do not suffer are in blue. The others are in red. And what you have there is the cells, lymphocytes and monocytes of these patients who circulate in the blood. We isolate them and we stimulate them using different pumps, the pumps which you have already listened from the previous speaker, endotoxins of gram-negative, proteins which mimic gram-positive, 5-hemagglutinin, candida albicans, pseudomonas, and staph aureus. And what we measure is the ability of the cells to produce IL-1 beta. And interleukin-1 beta is lower in patients with diabetes. And from the moment you do not have enough production of interleukin-1 beta, you cannot attract neutrophils at the site of the infection, and you cannot have phagocytosis, and all of a sudden you are at the risk for secondary just a proper glycemic control. How many of the patients with type 2 diabetes, they have a proper glycemic control? Less than 5%. Now, allow me to speak about malignancy. And again, what we believe is that the malignancy which counts are metastasis. What counts is that you have chemotherapy and you became neutropenic, or you had radiotherapy. And in our collection of data coming from the Greek ICUs, among those patients who are meeting the sepsis 3 criteria, we identified something more than 1.2 thousand patients without malignancy, another 126 with malignancy, and then we decided to identify patients with malignancy stage 1 or stage 2 with very good prognosis, with similar level of severity, similar pathogens to the other patients by propensity score matching 83 and 83, and look at the outcome. Those who have stage 1 or stage 2 malignancy, they have a signature of bad outcome by sepsis. So by definition, in other terms, all I want to say is that we narrow our minds to things which seems impressive, to things which are easy to conceive. And as always, we look at the tip of the iceberg, but we always neglect what the reality is. And sepsis, of course, is a life-threatening organ dysfunction caused by dysregulated host response to infection. But the idea is that we want, as you listened from the previous speaker, we are desperate to recognize that early. And early means not when a patient has overt organ dysfunction. It means, if possible, before even organ dysfunction arrives, and we rely on clinical score and biomarkers. And you listened already about how much we like the QSOFA score. Why? Because it's easy, it can be done at the triage level. It's easy to give separate points for mental confusion, 22 or more breaths, a systolic blood pressure less than 100. And the patients who have 2 or more signs, they run at more than 10% risk of death the first 20 days. But this is the reality. If these are patients in this panel at the right, indeed infected, indeed by SOFA score, they were meeting the sepsis rate definitions. And if from the very beginning they had 3 signs of QSOFA, the risk of death was 60%, with 4 signs, 40%, but with 2 signs, 1 sign, 20%. That means that the QSOFA score can work if you have 2 of the 3 signs. If you have 1 of the 3 signs, we cannot tell that our patient is not suffering from sepsis, but all of a sudden our patient is at the gray zone, and there we are in need of other scores. And if you compare the QSOFA to what we were doing earlier with SIRS, it's up to us to decide whether we prefer high sensitivity or high specificity. So if your QSOFA is equal to 1 and there are signs of infections, don't take for granted that your patient is not suffering from sepsis. You need to go to the National Early Warning Score, the News 2 by the UK, which gives separate points for the breath rate, temperature, systolic blood pressure, pulse rate, decrease of consciousness, and need for oxygen supplementation. And if your total is 5 or more, that means that you probably suffer from sepsis. But again, what is the real unmet need? Early risk assessment. Early means well before clinical signs of risk appear. Risk means that the patient may progress into organ dysfunction and die. But from the moment you assess this, what can you do? Will you build new ICU beds? How will you react? Because this is what counts. Because if you don't know how immediately to react, then all of a sudden you are at a big problem. Actually, what we know already, thanks to this seminal work by Annane, that what counts is to give immediately, if possible, the first 1 hour, one shot of antibiotics. And if you manage to do so, then the likelihood that you survive after 1 month is 80%. But for every hour of delay, the relative risk of death increases by 7.6%. So when I speak to my students, when I speak to my fellows about that, do you know what they understand from this graph? That you prescribe early antibiotics. Prescription is one thing. If you are at a setting where there is shortage of nursing personnel, how will the nursing personnel translate that they need to react immediately and not leave the prescription of an antibiotic sitting on a bench for 3 or 4 hours? So it's not only the physician's initiative, it is a collaboration with the nursing personnel. But when it comes to patients who are immunocompromised, then all of a sudden the question is not only to give antibiotics, but to give the correct antibiotic, an antibiotic which may be active against the pathogen. And this is a very interesting survey. It's a review coming from the Immunocompromised Society, chaired by Muratakova, and bringing together information about resistance to quinolones, to carbapenems, gram-negative producing ESBL, extended spectrum beta-lactamases, Staph aureus resistant to methicillin, enterococci resistant to vancomycin. And you see that even in what we traditionally consider the northern countries and the western countries, that there is no resistance. Resistance is everywhere, particularly, of course, the more we move to the south, resistance may well be above 50%. But if you are at a setting of resistance, and if your patient is immunocompromised, then you should not restrain from your patient as first shot of antibiotic a really newer beta-lactam with broad spectrum. Allow me to share with you a reality coming from my country, located at the south of Europe, in a publication which we had comparing intervention with immunoglobulins and comparators. But these are the resistant patterns of our isolates of Klebsiella, Acinetobacter, Pseudomonas in the ICU. And what appears originally frightening for us who are clinicians coming from southern countries, this is a reality. Apart from colistin, and even with colistin, we have here restrictions. Carbapenems cannot be a treatment of choice, and all our hopes relying on the new combinations with agents hydrolyzing carbapenemases produced by this bacteria. But I would like to leave you today with the message coming from the Surviving Sepsis campaign. You need immediately to cover empirically Pseudomonas, Acinetobacter, methicillin-resistant staph. You need to know very well your resistance surveillance. Your lethal treatment should be more than 14 days. And don't consider that this applies only for neutropenic patients. I want now to go back at the beginning of my presentation and show to you how much patients who are splenectomized, they run at risk of sepsis. And the need for both treatment is finally much outscored by this prospective multicenter randomized and blinded trial. It's more than 10 years ago, but so elegant, comparing piperacillin tazobactam versus the combination of pip/tazo with tigecycline, having as a primary endpoint successful response to treatment and all other situations, death, persistence of bacteremia, development of multi-organ dysfunction, relapse, and toxicity as failures. What was the major driver for failure? Monotherapy and acute leukemia. With this message, I would like to leave you to thank you wholeheartedly for this invitation, and I'm looking forward to our discussion.
Professor Giamarellos-Bourboulis, as always, insightful, discovering the new data not only from national but European-wide comparisons. And of course, again, the repeated emphasis on the need, on the critical, essential need of early detection, early recognition for the better clinical outcomes. And I believe the multidisciplinary approach, not only among the disciplines, but the engagement of nurses and the different frontline workers, that is something that I believe could be the start of our new collaboration with colleagues engaged in cancer. Last week, I had the honor of attending the European Cancer Organization Summit in Brussels, and we have experience from ECO colleagues for extremely. This is something that we could definitely facilitate in terms of capacity building very much. Before handing over to our next speaker, I would like to welcome colleagues from Sudan, United Kingdom, Rwanda, and the United Arab Emirates. Also, new colleagues from Nigeria joined. So we're very grateful for your continuous participation and also taking notes of the questions that are coming in. For the next presentation, it's my absolute honor to Dr. Diego Lopez Mendoza, the intensive care specialist and Menarini Global Medical Lead on anti-infectives, to his presentation. And I use the opportunity to thank Menarini Group for the collaboration and the new partnership that we started.
Thank you very much. It's my pleasure to be here sharing this amazing webinar with you. Mendoza, intensive care specialist and working as global medical lead in Menarini. And I am delighted to present this topic to the audience in the next 10, 12 minutes. So they wanted me to talk about the problem of AMR in cancer patients, and more importantly, what is needed to improve the looming that we are facing. We have been talking about the problem that is posing for cancer patients. This is clear because of all these features showing in this slide, but more importantly, we must not forget that infections are currently the second leading cause of death among cancer patients. This is something that deserves a lot of awareness attention from a multi-stakeholder perspective. Also, it has been mentioned, cancer patients face a threefold increased risk of death from fatal infections, and this is really worse when AMR is present. We know that AMR to worse antibiotic empiric therapy, lower rates of effective therapy, leading also to sepsis and worsening the outcomes of these already in patients. So it is a reality that we need to face already, that because our cancer treatments can remain or can become so useless if we don't act promptly to tackle the problem of infections in these. But it is not just about the clinical direct the infection. It is always a matter of a multi-layer approach. The AMR infections are also affecting and cancer therapies, and it occasionates a lot of delays in 1/3 of the patients, putting them at risk also to worsening the base disease, their cancer condition, their oncology process. But also it has an enormous. So we always talk about the threefold burden of AMR infection. It's clinical burden, of course, it's an economical burden associated, but more importantly, it's an emotional burden for the cancer patients when they suffer an AMR infection. So the question is, what can we do to combat AMR in cancer patients? So we have been talking about some of the key facts. progress made in cancer definitely undermined because of this problem. But I think we first focus on a multi-stakeholder perspective. This is a problem that is affecting functionally to all the healthcare systems. It's not just about the clinicians and of course the patients. It's affecting cross-functionality to all the healthcare systems. So the first thing that we need to do to combat effectively AMR in cancer patients is keep raising education and awareness. And the best way to do this through data generation. It has been already mentioned that we are still needing more data to put in the spotlight this problem. I use some very elegant and interesting data that have been generated only in the last. I wanted to focus on the most recent data last year with some amazing publications and studies that have been highlighting these alarming problems. So first, I wanted to share this that was published exactly 1 year ago, highlighting the burden of resistance in adult hospitalized patients with cancer. And as you can see, the conclusion were AMR rates for some pathogens were 1.5 to 2 times greater in hospitalized cancer patients compared with hospitalized non-cancer patients. The cancer situation, the cancer condition, the risk of acquiring this type of super difficult to treat infections. Same line, this same group of investigators 6 months ago, beautiful paper focusing in this time in the outpatient setting, patients with cancer in the outside of the hospital. And the aim was incidence and prevalence of AMR in these outpatients with and without cancer. And again, the conclusions were super clear and overwhelming. There is an increase of AMR in cancer isolates versus non-cancer isolates in these patients. Similarly, the AMR incidence rate ratio is higher, as you can see in the statistical significance for most of the important that are affecting this type of patients, and clearly high cancer patients compared with the non-cancer outpatients. And this was something that was consistent throughout all the different sources of isolation. Especially interesting or important the significance in blood and urine. And again, we all know that if we are not able to tackle and treat properly this type of infection, early diagnosis and early treatment and appropriate treatment, this could lead to this. And as Mariam was showing earlier today, sepsis means an enormous increase of mortality, likelihood of worse outcomes in these patients. So this is something that we really need to take and diagnose and treat properly. So the conclusions of this job were very again super clear. The prevalence was higher in these patients across multiple sources of infection and in a very distant manner. So definitely there is a problem that we need to keep focusing on. Another beautiful study published 3 months ago from Marco Palcone group was highlighting the impact of multi-drug resistance patients with bloodstream infections caused by gram-negative bacilli. The study recruited almost 300 patients. 80% were with solid cancer, and you can see the numbers are again overwhelming. Only 1/3 of these patients were infected by susceptible negative bacilli, meaning that 67% of these patients, 2/3, were infected by multi-drug resistant isolates with the mean that we have been already discussing: worse outcomes, worse antibiotic therapy, higher mortality, etc. As you can see in this graphic, it's super shocking. I mean, you can the image speaks by its the mortality among the patients with susceptible organisms was 7%, while the mortality in the resistant gram-negative bacilli more than 27%, with a clear statistical significance. The excess of mortality attributable directly to the MDR in solid cancer patients was 33%. So again, super statistically, and a clear message of the importance of this situation in patients. And finally, just a couple of months ago, we supported also this public multidisciplinary group. As you can see in the publication, there were infectious disease specialists, oncology, planted experts, patients, organizations in setting. So this was a multidisciplinary work where we again to highlight the problem and increase the awareness around it. And again, very consistent that resistant bacteria are common in cancer patients with median around 20% of frequency of AMR cultures among the large systematic literature review that we conducted. Also, carbapenem was especially important. When carbapenem resistance was found in these infections, that it was linked to fatal outcomes, longer hospital stays, more admissions, and another shocking number that we found, 36% 30-day mortality among cancer patients with this type of infections. And also the election of the initial antibiotic was a key driver. When initial empiric antibiotic therapy is inappropriate, again, we find worse outcomes, more ICU admissions, and higher mortality. I wanted to finish this section of the awareness also highlighting one topic, which is the physical, but also the emotional toll of the AMR among these patients. This is something that is under-recognized, and this that few publications really have been stressing, and there is a physical and a psychological distress for these patients, these cancer patients, when they risk or acquiring an AMR infection, because it means also isolation from their family, and of course it has a tremendous impact in their quality. So to conclude, and getting back to the first question that I was posing in my presentation, what is needed to improve the in the oncology setting and improving or at least reducing of AMR in cancer patients? I think first, education control. This is critical. Prevention always comes first. Second, antimicrobial stewardship in terms of fast diagnostic and accurate diagnostic. Third, early effective antibiotics. Otherwise, we could cure but lose the patients because of infection. Education and infection control are not just about hospital professionals. It's also about the whole environment, patients, of course, and the community. When we talk about microbiology, we talk about rapid diagnostics that could enable antibiotic use and optimal decision-making in escalation and de-escalation of the targeted therapy to better manage this type of infections in oncology patients. And finally, we need definitely to keep developing effective antibiotics therapy policies and ways to ensure antimicrobial stewardship across the hospital, but also the outpatient setting to avoid the outcome of sepsis. As it was also mentioned, and I think it's a beautiful way to put it, so it's very didactic, sepsis is the phase of antimicrobial resistance, and we need clearly to manage adequately and improve the poor outcomes of sepsis in these patients. The final slide is to strengthen the concept of the multidisciplinary approach. If we really want to make a difference and improve outcomes in cancer care, we need to act at a multi-layered from a multi-layer optic, and I am suggesting this 7-step action, call to action, to improve the situation. First, recognize again as a problem, increasing awareness, education. Second, embed AMR surveillance, including cancer-specific data to improve the management of these patients. Third, boost development of new antibiotics in high-risk patient population. Four, ensure equitable to antibiotics, which is not for granted. Still, there is a big inequity, and keep working from this multi-layer perspective to improve the situation. Invest in rapid diagnostic stewardship programs. Involve clearly patients. We need to listen to the patient's voice. We need to involve them in AMR research and care decisions. And finally, we need to foster this multi collaboration, public and private sectors, but also in terms of the specialty, infectious diseases, oncologists, transplant teams, and patient organizations. And patients must be in the center to really make a difference from this multi-layer perspective and change the looming that unlikely we are still facing with AMR, specifically in cancer populations. Thanks, and I will like to hand over to Mariam, and please, I will be happy to answer any questions of the session.
Diego, thank you for sharing these studies, the 7 action plan, the 3 pillars of our next steps and the focus. And again, your speech reaffirmed that we cannot continue the dialogue or work on AMR, sepsis, and cancer in isolation. We have to find the cross-cutting kind of journeys of collaboration. And I believe both the GSA and Menarena Group are excellent partners to facilitate those partnerships and joint learning through multidisciplinary approaches. I welcome colleagues from Brazil, Sudan, and Belfast, and we have one question regarding the NICE guidelines, but we will keep the questions towards the end of the session. Dear friends and colleagues, we've discussed a lot about the clinical epidemiology, the global estimates, the statistics, but I believe now we have 2 most important presentations of today's session. Presentations from people who were directly touched by the tragedies and life-changing experiences of sepsis and cancer. And I'm extremely grateful and honored that Dr. Nveed Chaudhary, the founder and trustee of Giamarellos-Bourboulis Sepsis Research Foundation, is with us. After the tragic loss of his young son, Dr. Nveed took the challenge of making differences and amends to the current realities of sepsis and cancer. Nveed, over to you, and I know that your story has already changed lives, and it's incredible what you have already achieved after going through this unbearable pain. So thank you once again, and handing over to you.
Thank you very much, Mariam, and thank you so much for the invitation and the opportunity to present today to a global audience through this webinar. As you said, my name is Nveed Chaudhary, and I'm the founder and the trustee of the Giamarellos-Bourboulis Sepsis Research Foundation. So far, we've heard a lot of science behind AMR and sepsis in cancer patients, and now I'd like to put a face to all the data that you've seen today and all of the clinical discussions that have been had so far. So, Giamarellos-Bourboulis is my son. He passed away in November last year. He was diagnosed with acute myeloid leukemia in August of last year. And when he passed away, he was 18 years old. He was start university. He was going to study theoretical physics. Fortunately, he chose not to pursue a career in biology like his father. He preferred physics as the son. That was the route that he was going to go down. Why did we set up the JCSR Foundation? Well, Gibran, as I said, presented with symptoms of respiratory infection, and this was at the end of July, beginning of August. And he was treated almost directly with low-dose broad-spectrum antibiotics from day one. A couple of days after having this infection and being with the doctors in hospital, diagnosed with having, as I said, acute myeloid leukemia. And he had a first psychotherapy, after which his leukemia was in remission. He then went through the second round of chemotherapy, and the remission stayed. So after 2 rounds of chemotherapy, he was in complete remission of leukemia. There were no cells that could be detected anywhere in his system. But as you will know, I'll explain later on, part of the treatment for hematological malignancies, especially where there's a respiratory indication, is on antibiotics, and that was the case with Gibran. He was on these, as I said, since August. As you know, for hematological malignancies, especially a stem cell transplant is the ultimate cure. And in Gibran, they had identified a donor in Turkey. The stem cells weren't going to be available for around 6 to 8 weeks after his second round of chemotherapy. And though the hematologists were adamant that had the stem cells been ready, at that point they would have gone straight to stem cell transplant and not had a third round of chemotherapy. Because there was this delay, they decided to give him a prophylactic third round of therapy. Post third round, whilst waiting for his bone marrow to recover, Gibran caught a skin infection. It was Pseudomonas aeruginosa. We've already talked about that bacteria today. And it turned out that Pseudomonas had developed antibiotic resistance. And he eventually developed sepsis, septic shock, and then multiple organ failure. Passed away in intensive care on a ventilator. And the reason we set up the foundation was because what I can't fathom is that in 2024, 2025 now, leukemia, but we can't treat infection. How can that be? Why is infection risk and infection management not taken much more seriously in leukemia patients going chemotherapy? In all honesty, the I felt and that I currently feel is that infection risk is a potential side effect of chemotherapy, and it's whether luck side or not on your side as to whether you could get an infection or not. The main is to try and cure the cancer, which, as I said, we can do very effectively. But it's just down to chance whether you catch an infection or not, and that can't be the way in which we can continue to treat hematological malignancies going forward. So this is why we CSR Foundation. So just a little bit of the clinical issues, and I touched upon this in his presentation, but I'll go through it very quickly. So the typical treatment regimen for hematological malignancy is a sub of chemotherapy, culminating in then conditioning therapy for then stem cell transplant. And at each of these points, you go through a condition which we talked about earlier, which is neutropenia. So this is a complete elimination of a complete emptying of your bone marrow. So to put it very simply, leukemia is, of course, a malignancy of blood cells. You can't get blood cells specifically, so the way in which treatment works is by eliminating everything in the bone marrow, all white cells, red cells, etc. And so what you're left with is a very profound and deep. And during this neutropenic stage, you are incredibly susceptible infection. And any sign of a cough or maybe a slight, which may or not be related to infection, but may be related just to the chemotherapy, etc. Prophylactic antibiotic treatment is given as the mainstream way of ensuring that in succumbing to infection. Once you're in a stage of neutropenia, as I said, you're at risk of getting a bacterial infection. But if bacteria is respondent to antibiotics, that's great. You recover from the infection, go into your next round of chemotherapy. The issue, of course, is if it develops antimicrobial resistance, and that can't be treated with antibiotics, you then go into a situation where you develop sepsis. It's really important to say at this point that infections don't have to just be bacterial. They can be viral, they can be fungal. Chosen to focus on bacterial here because this was a situation with Brown. Really what we are looking to do as a foundation is giving leukemia undergoing chemotherapy the best chance of survival. So how do we lower or eliminate the risk of infection with antimicrobial resistant bacteria during the neutropenic stages? The fact that antibiotic treatment is given for such a long duration means you're giving bacteria, especially bacteria which naturally live in your body, the chance of developing resistance. And that, Richard Brown, it was a bacteria that's normally found in your gut. Because prolonged antibiotic treatment, he developed resistance, the bacteria developed resistance, and then they're treated. So we developed a research strategy as a foundation, the type of areas that we're looking to promote and looking to fund going forward, and we call this PIT STOP, and it stands for prevent. We prevent people from catching an infection when they're neutropenic. Do we more quickly identify what the bacteria is? And then ultimately do identify the bacteria, how do we treat it without the use of the broad spectrum antibiotics being an issue? Ultimately to stop sepsis from occurring and an ultimate death. So potential research areas that we are interested in and we're discussing with academics globally. The first is around the prevent part of it, which is trying to protect the patient or prevent the patient from getting infection. So are there ways in which we can improve the physical protection for the chemotherapy patient? Are there physical barriers that we can use? Can we look at care protocols for patients to ensure that there's improvement to maintain hygiene of critically ill chemotherapy patients? Are there things that we can do with filtration to improve filtration systems to clean the air immediately surrounding the patient? Can we protect patients biologically? So as I said, long-term prophylactic antibiotics are deadly. Antibiotic resistance in bacteria is the problem here. So are there alternative antibiotic dosing protocols we should be looking at compared to what's currently been done today? Can we try temporary innate protection for neutropenic sepsis? There's a fantastic group in Oxford that I've been talking to who have identified a way of transplanting progenitor neutrophil cells stimulated in situ to offer neutrophil protection, which is transplanted whilst the patient is neutropenic and the bone marrow is recovering, to offer that from infection when they haven't got their own neutrophils. Are there differential chemotherapy approaches that we could be looking at? So, for example, as I said, instead of completely out the bone marrow and completely depleting the immunity of a patient, can we just target myeloid cells in the case of myeloid leukemias, or lymphoid cells in cases of lymphatic leukemias? At least leaving some levels of residual protection behind by attacking only half of the immune system rather than all the system. The third pillar is And this is Diego, you mentioned this improvement in the speed of bacterial characterization. Using Gibran again as the example, first seemed to get ill to the point where they identified what the bacteria was and what potential antibiotics could be used against that bacteria, determining that the bacteria was and had developed antimicrobial resistance. The time frame was about days. Can we shorten that? Are there technologies that exist? And again, we've as a foundation quartz crystal microbalance detection of bacterial strains. You can shorten bacterial identification from 7 days to something like 30 or 60 minutes. So some real cutting edge technologies out there that need to be funded in order to overcome this issue. And then the final pillar, using bacteriophages to fight infection as opposed to antibiotics, using monoclonal antibiotics to neutralize the bacterial toxins or target surface antigens. Again, there are technologies out there which use blood purification systems using machines with magnetic beads. There's lots of different systems out there, but again, it's the funding to these people so they can develop them and put them into clinical trials in order to be able to test and understand these technologies. And what I recognized in the year since launching this foundation, a lot of the big funding bodies that are out there that would typically fund this type of research are still more interested in trying to treat the cancer itself rather than just the effect of the infection that you might catch when you're on chemotherapy. It's almost like the infection part of cancer care is not sexy enough for foundations to focus on. And what we're looking to do is really focus on that, because as you said, Diego, very, very eloquently, we can treat the cancer, but only to lose the patient to infection, which is what happened exactly with Gibran. So these are the research pillars that we want to support, and we're actively trying to raise money, trying to work with other charities to focus attention on these pillars, which are important in this particular domain but also what we recognized is that in order to get these other charities and big funding bodies to fund such research, there needs to be the reason to do so. And the reason to do, other than the fact that these patients are suffering from this, is ultimately going to come from the health ministries, the Department of Health, on a global, regional, and international. So what we have started to do is we have started to lobby the Department of Health in the UK with regards to making infection prevention and management a key part of cancer care, specifically for hematological malignancies in the UK. And just last week was our Sepsis in Leukemia Awareness Week, which we launched. It was the first one this year. It started on the 16th of November, which is a year since Gibran passed away. And we were able to have a day at Westminster on Wednesday. MPs were given a ribbon. Quite a few MPs actually ended up wearing the ribbon. You can see here, the Prime Minister unfortunately didn't wear his, but at least his personal secretary did, and it was in view of the camera the whole time that we had PMQs on Wednesday. But a number of different MPs were wearing it. We had a lot of great interactions with MPs in the drop-in session that we had, and we asked the MPs that came to visit us to sign on a pledge board. The pledge board is basically them as co-signatories for an open letter, which is going to be sent to Wes Streeting, the Secretary of State for Health and Social Care. We're requesting a meeting with them to discuss the issue, to discuss the need for the UK to prioritize this in the national research agenda, to facilitate clinical trials within the NHS. We have quite a unique and also a fantastic opportunity in the UK with the universities and the NHS being so closely interlinked with each other. It seems quite a natural place in which you could try out some of this cutting technology in these extremely sick people. I should say that Caroline Noakes, who's the second picture down there, the lady sat next to me, she's a Deputy Speaker of the House. She's been absolutely fantastic in helping us get this voice in Parliament. She's really been helping us along the way from the very beginning, and promises to keep supporting us as we move in our journey forward. So Miriam, I want to end it there. Thank you so much for the time, but essentially we need to get this topic out there. We're starting in the UK. We want to get it to Europe, ultimately on a global level, to make people understand that this needs to become a central part of chemotherapy, especially for hematological malignancies. Thank you.
Nveed, we cannot thank you enough for being with us, sharing your the journey and the knowledge, the absolutely unique knowledge that you're bringing as a professional. I believe the pit stop, the concept is something that could be applied definitely globally. And as the first step, Global Sepsis Alliance will immediately invite you to the Global Sepsis Innovation Platform, the working kind of platform that we have established with the stakeholders. And I believe I'm using the opportunity of Evangelos' presence that to bring your experience from UK to broader region. We would be delighted to see you at the European Sepsis Alliance meeting in spring, where you would have the possibility of interaction with our colleagues from the different countries. This is absolutely amazing. It's incredibly heartbreaking, difficult to find any words of sympathy, but just thank you for the thousands of families that you're helping and you are trying to save from the same pain.
Thank you.
Dear colleagues, it's always very difficult to continue after these emotional speeches. I'm delighted to welcome colleagues and participants from Egypt, Colombia, Nicaragua, Zimbabwe, and Dominican Republic who joined the webinar in the last couple of months. And we are moving to our concluding presentation from Ilse Malfait, our dearest and co-fighter of the Global Sepsis Alliance. If you haven't heard about Ilse, this is an amazing woman who, surviving cancer and sepsis, has made historic changes in Belgium. Ilse will tell her story, of course, not going to the details, but you will see how impactful one person's fight to really touch the lives of thousands. Ilse, over to you.
Thank you, Mariam. Thank you for the invitation and for the beautiful words. My story began with a small lump in my breast, and the process of cancer turned our family upside down. We clung to the assurance that 95% survive. Took a family photo before I would lose my hair. Son Cass in the front of the picture found comfort in the idea he would be home more often. But fate decided otherwise. Just 4 days after my first chemo, I developed severe pain. My husband brought me to the hospital where a bowel perforation diagnosed, and I was rushed into surgery. The day after the operation, the pain was worse than before. That's normal, the doctor said. You will see. Within a week, you will be home. Every my youngest son, Cass, counted the days until my return home. And on the 6th day, he asked his dad, "Is Mummy coming home tomorrow?" At that very moment, I was being flown to University Hospital in an extremely critical, life-threatening condition. My chances had dropped to less than 5%. And my husband bursted into tears when he heard the question of Cass. Because images other than words, I made a video about the next part of my journey. The music you will hear is a song created by a friend who brought countless moments of light. It was written in Dutch, but I added subtitles for you.
Lieve vriendin, het is me wat geweest, harder dan hard, en dat is het nog steeds. Jij speelt de match van je leven met opgeheven hoofd, waar een ander allang had gezegd. Wanneer je huilt en je moedig naar me lacht, zie ik je licht, voel ik je kracht, denk ik mijn God, wat ben ik fier. Want je leert me, raakt me, toont me keer op keer, je maakt me beter dan wel ik. Lieve vriendin, lieve vriendin. Als ik denk aan wat nog komen gaat, alle pijn die jou te wachten staat, breekt mijn hart in 1000 stukken, maar jij hebt de lijn. Je knijpt me in mijn hand, veegt me gepieker aan de kant. Er zijn ook van die uren waarin de duisternis het wint, jij dan machteloos en blind. Leun dan maar op mij, weet dat ik naast je sta, tot je ogen weer gaan blinken. Een nieuwe dag begint, wanneer je huilt en je moedig naar me lacht. Zie ik je licht, voel ik je kracht, denk ik mijn God, wat ben ik fier. Want je leert me, raakt me, toont me keer op keer, je maakt me beter dan wel eer. Lieve vriendin, lieve vriendin.
The 7 hospital days foreseen 487 days in hospital. I underwent 20 operations. The cancer was only fought with a mastectomy. Chemo was out of the question. Sepsis weakened my heart too much. Every 3 months, I go annually for the cancer checkups. Once back home, picking up the threads of life proved more difficult than expected. I had had 2 time bombs in my body, sepsis and cancer. The contrast as a survivor of both was huge. Upon my cancer diagnosis, a war movement surged into action. But sepsis that had freak devastation and about which I had so many questions, hardly anyone knew. A cancer organization even told me that sepsis was not a problem in the Western world. I felt utterly alone and misunderstood. How could a disease I had never even heard of could have such catastrophic consequences? Eventually, I attended a congress of the European Sepsis Alliance. There, my eyes were opened. I learned about early warning scores and realized that many hours had been lost before I received proper treatment, despite being immunosuppressed and showing clear warning signs on the ward. Doctors later confirmed that minimal 24 hours were lost and that I lost my legs needlessly. At that congress, I also met 2 other sepsis survivors, one of them also a cancer patient. And together we founded the patient organization Sepsibel. To break the silence around sepsis, Sepsibel reached out to investigative journalists. And they made a triggering documentary around sepsis, and they brought sepsis to the front pages. The very next day, the Minister of Health addressed Parliament and promised a national sepsis plan. But until today, that plan still exists only on paper, and that hurts. And now I would like to end with a call of action. What we truly need is an integrated plan that connects sepsis, AMR, cancer, and other diseases for those vulnerable for sepsis. A regulatory framework that creates a safety net for people like me and for anyone who suddenly becomes a patient, so that no one has to depend on luck, on being in the right place at the right time. Our patient organization, Sepsibel, has grown faster than we ever imagined. Unfortunately, because of the lack of awareness about sepsis and the severe health challenges faced by our members, raising funds is difficult. Thankfully, we are supported by the cancer organization Kom op tegen kanker in Belgium, and we are very grateful for that. The link between sepsis and cancer is clear among our members, because 1/3 are cancer patients or their bereaved families. Many of those who passed away had received a good prognosis, hope for recovery, yet they were taken away within days by sepsis. And these currents, and we heard this story by Nveed, cut deeply. Their families are left with questions, with grief, and sometimes with guilt for lost hours. They should never have to carry these emotions. That is why it is so important to hold on to each other, to join hands as patients, families, healthcare providers, and organizations. Awareness, collaboration, and a strong regulatory framework will save lives. That is what Sepsibel fights for every single day, for people, for families, and for hope. Thank you.
Ilse, thank you immensely. Every time we hear your story, it brings the same emotions and the same admiration of what you have gone through and how you have turned your the match of your life into the new fight. And without any exaggeration, I want our audience to know that you have played the most critical role in ensuring that the Belgian minister would instruct the multidisciplinary experts team to issue the national report in sepsis. Yes, the national action plan has yet to come in Belgium, but the first step that you have already accomplished is absolutely admirable. And again, I believe that through your interventions and Nveed's interventions, we have really put the face of sepsis and AMR in cancer patients. And I believe that today's webinar will be truly the beginning of the new round of dialogue and possible collaboration, searching for supporters, searching for collaborators, for making sure that the intersection between sepsis, AMR, and cancer are not only recognized, but resourced and integrated holistically under the universal health coverage and broader health system strengthening approaches. Once again, immense thanks to our faculty. I believe that our participants have enjoyed the presentations, have learned a lot of new evidence and insights. And from the live chat that I'm trying to follow while the webinar is going on, we mostly have the greetings and thank you notes. We have 27 countries present at the webinar from the faculty and participants. And we only had one question, and I believe Evangelos or Naoyuki, maybe, if I could hand over this question to you. One of our participants was asking whether the quick software is still recommended by NICE, the UK National Institute of Healthcare, who is setting the guidelines. If we don't have the answer today, we could reach out to our Vice President, Ron Daniels, in the UK Sepsis Trust, and we will come back to you. We have the contact of the colleague asking the question. I believe Evangelos has left. Okay. We will double check the question and revert to you. There was an update of the UK NICE guidelines last year. That is definitely what we know, and the UK Sepsis Trust has been actively engaged. But as the guidelines are subject to national revisions, we need to reconfirm the latest recommendations. And if you don't mind, the Global Sepsis Alliance will come back to you with after double checking the information with our British colleagues. Thank you. Dear audience, do you have any questions or comments? Otherwise, we will close the session in the next couple of minutes. Just to remind you that you can see the live stream recordings on the same link that you have received through the registration or directly from the Global Sepsis Alliance announcement. And we would like to once again remind you that the Global Sepsis Alliance has opened its doors to individual memberships, irrespective of your profession. If you are the advocate of sepsis, if you're a healthcare provider, a policymaker, or just a champion of the sepsis cause and believe in the global action against sepsis and the global commitment to saving lives, you're cordially invited to join our membership and to receive the membership certificates. The details, again, you can see on the website of the Global Sepsis Alliance. Thank you very much. I'm asking my colleagues, Marvin Zick, who was instrumental in organizing this webinar. Marvin, thank you very much for your support. And also Simone Mancini, who has been coordinating the program and outreach to our wonderful faculty members. Do we have any questions coming in from from the audience? Double checking the. Okay. So let me once again thank our speakers, our representatives of the Global Sepsis Alliance, and again, thanks to the Menarini Group for making this webinar possible, and we look forward to our continued collaboration for raising awareness and capacities in management and prevention, early detection and effective management of sepsis and AMR in cancer patients. Thank you very much. And Global Sepsis Alliance will make sure that any questions coming after the webinar will be redirected to our experts, and we will come back to you. Thank you.